Good evening, everybody here. And today is the week number 16 in anesthesia and critical care refresher course. And good evening, everybody here. And today is the week number 16 in anesthesia and critical care refresher course. And as usual, we have two lectures tonight. The first one will be about hemodynamic monitoring by Dr. Ahmed Mady. And the second lecture will be with Dr. Amr Salam and awake craniotomy, the anesthetic approach, and more. So let's start straight away with the first lecture with Dr. Ahmed Mady. So Dr. Ahmed Mady had got his medical degree in 1993 and his master's in 1998 and his MD from Tanta University Hospital in 2008, more than 12 years ago. He had the fellowship of critical care medicine in 2012, and he is currently an assistant professor on two universities. First one in Egypt is Tanta University Hospital, and the second one is in Saudi Arabia in Riyadh, Muhammad bin Saud Islamic University in Saudi Arabia. And he is as well a fellow of the critical care medicine in the American College of Chest Physicians. He is the program director of critical care fellowship and residence program in the MOH in Riyadh. So he is an eminent speaker, and Dr. Ahmed has a lot of research interests. I saw him doing his first, or one of his very first researches in H1N1 in 2011, and in the MERS-CoV after that, and after he's interested now in the COVID-19, hemodynamic monitoring, a lot of researches as well in different critical care hot topics. So I watched and listened to Prof. Ahmed Mady multiple times teaching in different hemodynamic monitoring tools and new equipments. So it's my pleasure to invite him tonight again and speak of one of his points and areas of expertise. And Dr. Ahmed, please start sharing your screen and go ahead. We are all ears here. Thanks so much.
Okay. Thank you, everyone. Thank you, Dr. Walid, so much for this very nice presentation. Actually, me and Walid are friends since long time back, and very generous presentation is always giving me more than what I deserve. Assalamu alaikum, everyone, and I hope you have a very good night, academic night today with the refresher course, a very distinguishable event, and I'd like to start with the hemodynamic monitoring in ICU. It is a huge topic. When Walid asked me to present overview of hemodynamics, usually it would take almost days to present overview of hemodynamics or hemodynamics. So I tried as much as I can to touch every part of hemodynamics. And the main concept of these presentations to open your mind and storm your brain how to think about the patients when you need to deal with hemodynamics in circulatory failure patients. First of all, I don't have any conflict of interest, but I can disclose that I retrieve many slides from the figures of the hemodynamics worldwide, like Prof. Tipoul, Xavier Moni, De Becker, Ken Inchi, and Jean-Louis Vincent. So I retrieve some of their slides actually to show you in this slide. I'd like to also announce I have many flowcharts I try to read by myself, as well as quoted from others. I hope it will be beneficial for everyone as a collective hemodynamic parameters. As of all, you know that hemodynamics, one from the very important cornerstone of the monitoring in the ICU. And usually you need hemodynamics when the patient will be in shock, either to help you to diagnose the type of shock, as well as management tool to help you how to deal with the patient at the therapeutic range. And the most important, to predict it early as a preventive measurement, not to wait until the patient will be in failure to have the to use your tools of hemodynamics to diagnose your patient. For example, if you take this a very common case, all of us have it in our ICU. You can find a patient which is old age coming to your ICU, which is known to be bedbound and admitted in shock state. The first impression in ER, they diagnose her as UTI. She's done the M and the hypertension, ischemic heart disease. She received 2 liters of crystalloids. Her MAB was 55. Heart rate is 120. Urine output is low. Capillary refill time is prolonged. Of course, when you look by IVC, I'm always consulting Walid. This is an area of interest, as well as our Prof. Ashraf Tayyar. They have the empty IVC as well as the poor cardiac function. If you look to this slide, you can find many hemodynamic parameters. Just look at the blood pressure, heart rate, urine output, IVC, contractility. All of these are items or parameters of hemodynamics. How you can integrate all of this to diagnose this case? This case may be somewhat clear, but if you look deep in this case, you can find she's bedbound. She can be as obstructive shock. It can have PE. She's also ischemic heart disease. She can be cardiogenic also at the same time. And UTI is the first impression. So it can be any type of shock. So you have different scope for shocks in these patients, and you have different parameters. How you integrate all to help you, how you manage this patient from hemodynamic point of view. I just remember a long time back when I'm studying, when I'm teaching my students about the shock stage, I'm telling them when you think about shock, just think about the garden, right? Of course, if you want to supply your garden with water, what do you need? You need a water pump, you need a hose and a release valve, as well as you need the water itself. The same like shock. Those are the types of shock. When you feel your patient have a pump failure, so his problem will be in the heart. If you have the problem with the vessels, either due to obstruction or vasodilatation, so you have a vasculature problem, either distributive or you have obstructive shock. Of course, if you have losing for intravascular volume, so you are dealing with the patient with the hypovolemic shock. So we will retrieve from this a perfusion of triangle. Perfusion triangle, which is the heart, blood, and vasculature. It's very essential to help you to diagnose this case as well as to treat here. So think about this garden when you're dealing with the patient in shock. Of course, the complicated case have mixed type of shock. Another very, very important message I want to tell you. When you look to this perfusion triangle, you can divide the shock stage into different phases, different categories. If you will start to treat this patient with the fluid, let us see here. When you try to treat the fluid, what's your target? All of you said, I want to keep MAP 65. I want to improve his cardiac contractility. I want to improve his oxygen carrying capacity. I want to improve his oxygen delivery and the oxygen saturation. All of this considering your target when you start to treat. But don't forget to look at the last station, to look at the end user, which is your cell. You have to monitor the downstream, because the main definition of shock is cellular hypofusions. So keep in your mind the target at the end to be your cells. And we have interface, we have intermediary phase between both of them. So if you are looking to the upstream, which is macrocirculation, and you are targeting to monitor the cell function at the end, you still have in between the microcirculation. The microcirculation, another category, another phase. So I'd like, actually, when you think about hemodynamics, to think about those three phases, those three stages: the macrocirculation as well as the microcirculation, and keep in your mind to follow up and monitor the cell's function itself. When you have this diagram in your mind, you will know, first how to deal with the shock patient. All of us looking to the macrocirculation, which is, we are assuming we have a patient with cardiac output. The cardiac output, the four determinants of the cardiac output, all of us will be happy if the heart ejects a good amount of the blood, which is stroke volume. But we need to think how this can be done. It can be done through improving the four determinants of the cardiac output, which is the preload and cardiac contractility, as well as heart rate, and of course the resistance in front of the heart, which is afterload. So even though I'm recommending don't keep those as objective, those are tools, and the monitoring those parameters are tools in your hand to help you to achieve your target, which is the cell function at the end. So if you are looking to the circulation, you can find this is the, keep in your mind this circulation, systematic circulation. Of course, I will not go in details because pulmonary circulation has also influence on the hemodynamics, very essential, but the main circulation we have is the systemic circulation. Looking to the preload in the venous side, looking to the heart as the contractility, and of course in the arterial side, which is the afterload. Again, your target is cells. And in between the macrocirculation and cells, as we have mentioned earlier, is the microcirculation, which is the very, very important. If you are looking to the history of hemodynamics, long history, long time back, when they thought that the flow is bumping by the heart, so they start to feel the pulse. When they start to feel the pulse, to know how much of the amount of the fluid of the blood moving inside the arteries. After that came the sphygmomanometer and the blood pressure. Then it came to us the Fick principle, which is the first robust cardiac output monitoring through a principle which is created by him, which is saying the blood flow to the any organs is equal to the amount of, let us say, indicator take by this organ divided by the arterial oxygen content of that indicator. This indicator can be a dye, like Hamilton said, and the first one, which is Werner, did use the dye indicator indocyanine green to estimate the cardiac output in 1956, and he awarded a Nobel Prize in the physiology and medicine during the time because he's measuring cardiac output. After that, 1970, of course, came the idea of the pulmonary artery catheter and the balloon floating to reach the pulmonary artery, and he can now differentiate between the right and left side, and he can estimate the cardiac output. From 1970, many devices coming to the market, many. I can say Bico, Nico, Vigilio, Ledico, EV1000, many of them, even microcirculation, cytochrams, oxygen saturations, all of them came to tell us we have tools which can help you to determine the patient. All of this, mostly, they are pointing at the macrocirculation. If I did ask you a question, please reply in the chat box. What is the most important and the first hemodynamic tool? When you have a patient in shock or whatever, what is the first hemodynamic tool? I hope to receive some answers in the chat. Just tell me the first and the most important hemodynamic tool. I cannot see the chat here. Let me try to find it. Yes. Heart rate, blood pressure, urine output. non-invasive blood pressure, capillary refill, very good. MAP. Okay, that's enough, please. I'm agree with you, but with very little percentage. You know why? Nowadays, I'm watching the series of the physician. Those, you and me, are the first and the very important tool of hemodynamics. You can imagine if you have really, yes, the physician is the first hemodynamic tool. You can imagine if you have this screen in your monitor with multiple of parameters, blood pressure, pulmonary artery pressure, wedging pressure, cardiac index, whatever you said, many parameters. And you don't have the personnel which can interpret these parameters. It's useless. So you, as a physician, is the first and the important tool. Don't forget your clinical sense. Don't forget your physical exam. Don't forget your interpretation of the parameters. This is the most important point and the first message I'd like to convey to you tonight. You is the most important hemodynamic tool. Of course, if you go to the basics, you can find many of them. But like heart rate, as you have mentioned, like blood pressure, like every basic hemodynamic point, all of them are essential. But unfortunately, all of them didn't have the sensitivity and the specificity which can tell you where is the problem exactly. Even the blood pressure, you can find the patient whose blood pressure is normal, but is still complaining of low flow. If we take the blood pressure as a hemodynamic tool, as some of you mentioned in the answer, blood pressure is not only the systolic. Systolic can give you a reflection of the stroke volume. Again, when you think about any parameters, try to think about the main concept we have mentioned earlier, which is contractility. So stroke volume can give you a clue about the stroke contractility, how much stroke volume. What about the afterload? Yes, MAP can tell you what is the resistance in front of you in the heart. And the diastolic can give you, the diastolic blood pressure can give you reflection about the systemic vascular resistance. And the MAP, which is a very important parameter for the blood pressure, can give you a hint about the perfusion to the organs. All of us know the target MAP for everywhere for septic shock patient, which is enough to have patient with 65 in circulatory shock patient. But consider, even this number of 65 is not absolute. You still have the patient who needs higher. You still have patient which can tolerate lower with the same perfusion, with good perfusion to the cells. So dealing with the number, don't make it a fixed number. You have to deal with adequate parameter figures. You are not dealing with absolute number of whatever you have. So MAP, one from the very essential tool in hemodynamics, but why you are selecting MAP rather than the diastole and systole? If you look to this MAP is the driving force to the organs. It is the perfusion to the organ. For that, all of them, they said MAP is very essential for the hemodynamics. Again, MAP doesn't affect the distance from the heart. Whenever you are measuring the blood pressure from anywhere, from the aorta until the saphenous artery, MAP, it is almost the same. MAP reflects the true blood pressure inside the whole vasculature, and it doesn't affect by underdamping or overdamping. So MAP is essential for that. So how we can calculate the MAP? If we go back to the physics again, Ohm's law tells us MAP, it is the multiplying of the flow and the resistance. Of course, here the flow is the cardiac output. So cardiac output, which is stroke volume multiplied by the heart rate, multiplied by stroke by systemic vascular resistance. So when you think about why your MAP is low, you have to think about these parameters. Again, stroke volume, which can give you a clue about how much the contractility of the heart, of course, will be affected also by the preload and afterload. So when you have a patient with low MAP, think about heart rate too high, too low can causing low MAP, as well as vasodilation, which is affecting SVR. So when you think about MAP, think about what factors can giving you low MAP for such a patient. Is it afterload, or is it the contractility of the heart, or it is the preload, or we have heart rate affection of the MAP? So don't take it absolute again. Think about the meaning behind the parameter you will have. If we go through the cardiac output and MAP, some flowchart to give you clue. For example, if you have the patient with low MAP and high cardiac output, so almost this patient have vasodilatation like septic shock patient, or you are using vasodilators. If you have low MAP with high cardiac output, with low cardiac output, so almost the problem would be in the preload or in the heart failure. But can you have a patient with high MAP with dropping cardiac output? Yes, if you are using excessive vasoconstriction like vasopressors or pain, or if you can have a patient with high MAP or high cardiac output like the patient with fistula, like using extra entropes or extra fluid resuscitations, you can have those patients with high cardiac output with high MAP. So coupling the ventricular function with the MAP, you can reach to your diagnosis. This is the first parameter, which is basic parameter. The second basic parameters, which is all of us know about it, which is the central venous pressure. Central venous pressure is a huge dilemma. They have a very common survey published and distributed in the worldwide. They're asking the anesthetist, which is the most important parameters guide you for the fluid management for your patient, either pre-operative in ICU. Most of them, 75% of them replying central venous pressure. And the dilemma of central venous pressure worldwide until now. Is it useful? Is it harmful? Shall we use it? Shall we not use it? Many updated literature talking about this, and I do recommend to repeat out. I collected most of them, and I can disclose. This is, for example, 33 statements for the basic hemodynamic monitoring published by all figures worldwide about the hemodynamic. They said CVB should not be used to predict or guide fluid resuscitations. So, shall we remove it? Shall we discard the CVB now? Still, my opinion, not no. You have to use it. There is a space for central venous pressure to can use. If you think again about the same circulation, CVB affected by the cardiac function, which can give you back pressure, as well as the venous return. Venous return have two important factors: main systemic pressure in the periphery of the veins and the upward pressure, which is central venous pressure. So central venous pressure, it is the upward force, upward pressure of the venous return. So when you think about central venous pressure, you have to think about venous return as well as the cardiac function. Yes, it can give you clue about the preload, how much inside the systemic circulation, venous circulation, but it will never give you clue about this patient will respond to the fluid or not. So keep in your mind, when you have CVB going higher and still cardiac output, significant rise in cardiac output, so it means your patient have almost right ventricular dysfunction, and this patient candidate of echo. So I think it is very essential to know the limitation of central venous line. Still, you need it for the perfusion of any organs. If you look to the perfusion pressure for any organs, still the CVB is present. So you have to use it to know how much the fluid inside the preload, but don't use it as a marker for the fluid response. And you have to know the limitation of CVB rather than to discard it completely from the ICU. This is the basic parameters in hemodynamics. Don't forget technicality points, how to connect it, how to make zeroing, how to make leveling. So again, if you never mind, this is small, very hint about the technical leveling and zeroing of the lines, whatever you are, central venous line or pressure. This patient, for example, 40 years old, they connected him with the A line in the radial artery. They make good zeroing for this patient. And after that, blood pressure at that time was okay. After that, his wrist fall down, arterial catheter in the radial artery, and fall down from the bed 20 centimeters below the heart after zeroing and after leveling. How well blood pressure displayed on the monitor compared to the patient's actual blood pressure? You understood the scenario? A line in the radial artery, zeroing done, leveling done, reading very well, then the rest fall down. So the pressure on the monitor, it will be 20 millimeter mercury higher or 15 higher or equal to the actual pressure or 20 millimeter lower. Let us see how it's doing on. A, C. Okay. Of course, sorry, I didn't do polls. Huh? But I can see all of you answered all the answers. We have A and we have B and we have C. Let me tell you the message from this one. Actually, the right answer is C. Whenever the catheter it doesn't affect your reading. What affects your reading is the leveling, the transducer level. You see also even the technicality, the nurse rule and the zeroing and the leveling is very essential to have a good and the correct number. So if transducer on the same level, so almost you have actual number. This is the same. But if you take the transducer above, right? So we'll have now false lower reading than the actual. If you're taking the transducer lower, so you have false higher than the actual. So this is just a hint or refresher to keep you in mind about the technicality of even using the parameter, not only the beneficial, the interpretation of the parameters, also the technical has an important point. Oh, again, let us see, we have certain figures. Always nowadays in the medicine, they said, don't rely on the static figure. Static figures, whatever it is, even in the infection. If you did ask, how much leukocytic count today? It is 12. What does it mean for you? It's 12. Yes, it means something if yesterday was 8, was 7. So the titr, the dynamic change of the figure, is very essential and it is more robust than the static figure. Dynamic parameters in hemodynamics, it is a part of the intervention and measurement. You have the parameter to measure, you have intervention to be done, and then you will measure the same parameter again. And you will check how is the effect of the intervention of the parameter you have measured. They are relying on the mechanical ventilation to increase the venous return to the heart, and they are checking the stroke volume or the pulse pressure to tell you how is the effect of the preload increasing or augmenting the preload or the challenging of the preload on the cardiac output. This is the dynamic indices. We have many of the dynamic indices as well as the static measurements. CVP, pulmonary arterial occlusion pressure, global end-diastolic volume, flow time corrected by different devices. So many devices giving you the static measurements. Of course, dynamic would be better. As we have mentioned earlier, whatever the dynamic you have, whatever the tool or the test you have, dynamic means you have monitoring parameter, intervention done, and then you are monitoring the same parameter again. The most common, all of us knows, we are relying for fluid responsiveness. We are augmenting the preload. We are changing the preload with the mechanical ventilation cycling change during inspiration and expiration, and you are expecting the preload will increase on the Frank Starling curve. So we have positive fluid response. So this patient almost will respond to the fluids. Whatever you are measuring, stroke volume or pulse pressure, whatever you are measuring in the parameters or in the monitoring tool, right? Keep in your mind, we don't have fixed graph for each patient. Even in the same disease with different stages of the shock, this graph can change. It is totally dynamic. So this patient can have septic cardiomyopathy. The heart cannot respond for the preload. At this stage, it will not be responsive. Right? So when you think about dynamic and the fluid responsiveness, you have to think about the status of the heart. Does it respond to the preload or not? As well as the stage of the shock itself, which is very essential because it is related to the timing of the response to the fluid. Again, what intervention here? Mechanical ventilation changes. What the response here? It is the stroke volume. You can take on that many of the parameter or many tests to be used for the fluid responsiveness. Of course, hundreds of literatures, they are comparing the static versus dynamic. Of course, dynamic always won. Pulse pressure variation, stroke volume variation as regarding sensitivity and specificity. The same concept like the interesting, the very, I cannot say new, I can say now point of care, the point of care monitoring parameter for the patient with ultrasound and echo using the same concept. Intervention and response, whatever on the level of the inferior vena cava, superior vena cava, or aortic, or LV outflow tract by echo. So the same principle. Again, I will not go to each one in details, but I just want you to remind you with the limitations. Before you will know the beneficial of any test, you have to know what is the limitation of that test. You can see it here. We have, it is well known, well-established predictor for volume responsiveness, but we have many limitations you have to consider when you are dealing. The patient have high intra-abdominal pressure, the patient have so much arrhythmia, the patient having right heart failure. All of this were reflected on your the fluid responsiveness test. So what you will do during this stage, you will just change the intervention from mechanical ventilation to another intervention to be done, doesn't affect it by the cyclic change of the pressure, which can be occlusion of the expiration or passive leg raising test or many fluid challenges, and the parameters you are measuring would be the same: pulse pressure, stroke volume, aortic VTI, or the diameter of the IVC or SVC. So fluid responsiveness, again, is a tool to help you to predict, does this heart will respond to the fluid you are giving or not, which is very essential. Many, I can say more than 300 literatures coming to the market to assess the sensitivity and the specificity of the fluid responsiveness. And of course, it is well known to be used for the shock stage patients. Okay, so what about the heart itself? What about the stroke volume? How you can measure the stroke volume and cardiac output? If you look to the technologies, many technologies, and I'm not here to give you like a shopping mall or a shopping market to marketing devices. No, I'm just giving you the concept. We have many concepts or many technology behind the estimation of the cardiac output, like thermodilution. The first one used by the Swan-Ganz. After that, it came transpulmonary indicator dilution and arterial pressure waveform interpretation. It can give you clue about the cardiac output. Esophageal Doppler, echo, carbon dioxide rebreathing, depending on the fake principles, or bioimpedance and the bioelectrons, which is the least sensitive, least invasive maneuver to measure the cardiac output. So much technology is coming. The first one and the gold standard with the highly invasive one, which is the pulmonary artery catheter. Of course, it is not now the time to discuss it in details, but I just want to tell you, even when you are interpreting the data by pulmonary artery catheter, you have to think about the main concept. What parameters can give you clue about the preload, which is stroke volume, can measure CVP, occlusion pressure. The other parameter can give you hint about contractility, cardiac output, cardiac index, stroke volume of the left and right side, and also afterload. So when you think about the device, please think and interpret systematically about this device. What parameters give you clue about the preload, contractility, as well as afterload? Of course, all of us know the debating about we have to use or we don't use the pulmonary artery catheter. It is long debate since long time. Many meta-analysis done to tell us pulmonary artery catheter, it is neither increased overall mortality or days in hospital nor conferred benefits. But in well-trained hand, still it have a space. And believe me, all the new devices we heard about, all the devices, comparing the accuracy and validation by the pulmonary artery catheter, this is what was the gold standard. Then they are kicking it out. So it is a gold standard. It has many complications. The most common complication of the Swan-Ganz is interpretations, misinterpretation of the parameters, right? But still it has space for the patient to have ARDS and complicated cardiac function and cardiac dysfunction with the ARDS. Another very nice and non-invasive tools, most of anesthesia they are using in the pre-operative stage, which is esophageal Doppler. Just a probe, you can pass it inside the close to the descending aorta, measuring the descending aortic blood flow, and give you a graphs and numbers. Very simple technique, esophageal Doppler, to measure the stroke volume. Again, even with this device, think about what the parameters can give you hint about the preload, flow time corrected, how it looks like if you have preload reduction or this patient needs flows to increase the preload. What about what the parameter giving you afterload? Yes, stroke distance, how far it will bump the blood, how far the distance from the stroke volume from the in the descending aorta, and it means this patient needs afterload reduction. Microcontractility, peak velocity, how high of the wave, the peak velocity, also contractility. So again, think systematically. When you have a device, think, interpret the parameters systematically. The another techniques, which is almost all of us know, transpulmonarythermodilutions. The most two common techniques in all devices you have on the market, either pulse contour analysis, which is using analysis of the pulse pressure, or time integral for the dye, whatever the dye. Can be the temperature, can be the option, can be the carbon dioxide, which is transpulmonary thermodilution using the cold saline to measure the stroke volume through two lines one in the central venous catheter and another one with the thermistor in the arterial side outside the thoracic cage. So we call it transpulmonary. Many parameters you have to get through them. The most two common devices measuring the using the transpulmonary thermodilution is EV1000, which is the more recent one, and the PICO, which is the almost old one, and both have the same parameters, right? So transpulmonary thermodilution, these devices are comparable to the gold standard, which is the pulmonary thermodilution, which is the pulmonary article. So we will have the screen of both of them. Oh my God, it's complicated. Yes, but again, think about systematically. What the parameter in this screen give you clue about the preload? Just take a look. If you look here, we have global endostolic index, which is the amount of the blood in the fourth chamber at the end of the diastole, as well as CVB. The same, two monitor, we have the same global endostolic volume as well as the CVB. Plus, of course, the responsiveness we have here, stroke volume variation or pulse pressure variations. So this is the preload as well as the responsiveness. If you think about the parameter who can give you clue about the contractility, yes, we have global ejection fraction, stroke volume index, or we have cardiac function index or cardiac index on the other device, whatever is it. If you think about the afterload, we have SVR and MAP. Look at here. So interpret the parameters of the monitor, which is almost complicated monitor. So when you think about systematically, you can reach to the diagnosis as well as the intervention you need to do. Very essential parameter here to be added for the transpulmonary thermodilution, which is the safety. When you have to stop, when you have to take your fluids out, this is the very essential. Look at here, the parameter giving you this clue, which is extravascular lung water as well as pulmonary vascular permeability index. In both parameters, we have it here in purple. You can see it here, this one and this one. So those are the safety and studied very well in the literature, as well as some monitoring giving you continuous measurement of the central venous oxygen saturation. Like here, you can find it continuously, assessing the balance between delivery and the utilization. The importance of the safety parameter, let me focus on this one. As all of us know, your lung is dry, dark, and dank space to allow gas exchange easily. Extravascular lung water, any fluids outside the pulmonary vasculature. You can imagine it is very less amount. 200 ml of extravascular lung water, the patient will be drowning. In the literature, very good marker for the mortality. You can be doubling of the extravascular lung water, you can find mortality reaching to 50%, significantly high. So very high risk and sensitive marker you have to keep in your mind when you're dealing with the shock patient, especially shock ARDS or cardiogenic, both of them, because it will answer the question when to stop fluids and when to remove it from the body. Another flow chart, I like to have it here. It is published 2018. If you can see it here, this is just to compare. If you have the patient with normal lung, so almost he has low vascular permeability as well as low extravascular lung water. If the vascular permeability increasing, as you can see it here, ARDS at risk without increasing the extravascular lung water, right? If only extravascular lung water increased and pulmonary permeability index is low, so almost your patient have left ventricular failure and hydrostatic pulmonary edema, cardiogenic pulmonary edema. So vascular permeability give you clue about which type of shock you have. It is cardiogenic or it is non-cardiogenic. Simply through this one. Okay, so we have many devices now on the market. So what can I will use? Which device and for which patient? This slide or this title, it is another lecture alone. But just I will give you a hint. Simply, you have many parameters to assess which device to use for which patient, based on the technology, based on the invasiveness, based on the which is more accurate. But simply, Allah ymasih bil khair, Dr. Gamal Hashimi, I think Dr. Riti knows him well. He was working in his center in Jeddah. Now he's in Canada, right? He published in 2015 a very nice integrating of the cardiac output based on the setting. He mentioned if you are in the ward, you just need the less invasive techniques. like bioimpedance, like Doppler, like non-invasive. If you are in emergency department, maybe you need uncalibrated, or we can say self-calibrated, like Vigilio or like Ledico. If you are in OR, maybe you require, if you have ETT, you can use bioimpedance, you can use NICO, you can use applied fake principle, Transesophageal Doppler, or uncalibrated technique. But in ICU, the patient is always hyperdynamic. The shock is not, it's not stationary phase. So you need more advanced technique, which is almost the either pulmonary artery catheter or calibrated, which is either EV1000 or PICO. So simply where you are using the device, right? Okay, so one from the important flow chart. Let us put everything together from the macrocirculations. What you have to do, and what we are doing in our center or everywhere, in our ICU and everywhere. If you have the patient in shock, first assess his cardiac function to exclude cardiac element. If his normal cardiac functions, just look to his lung. If we have lung injury, if no lung injury, only cardiac output, only shock stage, shock, so we need only basic monitoring. Basic monitoring, which is mean central line and arterial catheter. But if you have the patient with lung injury or limitation of the fluid responsiveness, or if your patient have abnormal cardiac function, so those patients need advanced techniques, either pulmonary catheter or they need the Transpulmonarythermodilution techniques. So simply assess your patient, right? If his only cardiac function circulatory shock, so needs simple techniques. If it's combined circulatory with cardiac and ARDS and limitation for the test you have, you need those patients to go over more advanced techniques. Let me another question I will ask you. I found in my ICU and everywhere, you can have many patients in ICUs with this screen. Blood pressure for this patient, he's a septic shock patient, but blood pressure 100/60, and the heart rate saturation accepted. But you can find your patient have this picture, or he have delayed refilling of his capillary. Are you happy to have the patient with target map 65 and still have these signs? Of course, no. Right? We did agree for that. Why? So you need to think, you need to retune your targets. MAP is not a target, it is just a tool to reach to the microcirculations. Those patients have lost the coherence between macrocirculation and the microcirculations. Keep in your mind to treat this incoherence between macrocirculation and the microcirculations. Again, I will remind you with this picture, with this slide, you have 3 stages. You can have shock in the macrocirculation, but the patient is okay in micro and in the cell perfusions. And the most important, you can have normal macrocirculation in this stage, but still you have problem with the microcirculation and downstream in the cells, hyperperfusion. So you need to think about those. You need to think about the parameters who can give you clue about the micro as well as the cell function. Simply, perfusion markers can be done through, as we have mentioned earlier, the clinical examination. Skin temperature can give you clue. Does the skin warm, cold? Capillary refill, one from the, let us say, primary assessment for the patient in shock stage. If, of course, it's prolonged more than 5 seconds, to be associated with poor prognosis. Skin mottling, one from the very common score in sepsis, you can find it with the severity. With the high score, more patient will die. Less survival, as you can see in these studies. It is well studied, well done. And you can see it here in the knee or in the elbow. Whenever you have mottling higher, more patient will die. Of course, this is just a clinical examination and assessment. You need to have a biomarkers. You need to have indicators. Now, the most common indicators you can find is lactate, mixed venous oxygen saturation or central venous oxygen saturation, as well as carbon dioxide gap. All of us knows lactate is the hallmark of shock. Believe me, first thing you need to ask about it when you have a patient in shock, how much is lactate? Is it cleared or not? It is very well studied since long time back. It is not new, right? Even in the absence of physiological derangement. Even, I have a case, real case, all his microcirculation it is normal, but his lactate is was always 4.5. Even she's conscious, she's doing very well. I have real cases like this. We discovered with time she has ischemic bowel, she has peritonitis, she's developed septic shock later on. So lactate, one from the very essential tissue biomarker for the perfusions. Moreover, lactate correlates well with both macro hemodynamic as well as tissue perfusion. Many studies just to compare. With higher lactate, more patients will die. As you can see in this study, survival only 30% when lactate more than 3.5 millimole per liters. And if you are targeting lactate during your management, less patients will die. Not only the figure of the lactate clearance. Lactate clearance, you can see it here with days. Probability of survival will be higher if you clear your lactate earlier. So please, I don't like to say don't forget, because one from the essential to deal with is the lactate with the patient in shock. The second biomarker is central venous oxygen saturation, or we can say mixed venous oxygen saturation. It is indicator of the balance between oxygen utilization as well as consumption, supply and demand. So when you have the equation to this is mixed venous oxygen saturation, you can have four determinants. If you look at them, it is saturation, oxygen consumption, cardiac output, as well as hemoglobin. This is common equation in the hemodynamics. If we did fix the oxygen saturation and hemoglobin and the oxygen consumptions, cardiac output would be correlated with the mixed venous oxygen saturations. There is difference between mixed and central venous. So it's not the time now to go in depth what is the difference between both of them, but you can find them, both of them correlated. And many studies and meta-analysis showing there's a good correlation between mixed venous oxygen saturation and central venous oxygen saturation. Right? So we talk about central venous oxygen saturation now, and it is a very good marker to give you a clue about the balance between supply and the demand. So let us put it in the flow chart. If you have the patient, so again we said the balance between delivery and utilization. If you have low mixed venous oxygen saturations, so almost either due to decreased delivery, due to hypovolemia or low cardiac output, or increased consumption, like the patient in seizuring or shivering. If you have the patient with high venous oxygen saturation, just take EBG and check how much the saturation. Either delivery will be high with hyperdynamic circulation, with more fluid, with more entropes, or utilization will be low with the patient who is in sedation or hypothermia or shunting at the end of the sepsis. So central venous oxygen saturation you can rely on to give you clue about the balance between utilization and delivery, but not the quality of the perfusion at the level of the tissues. Yes, it can tell me I can increase the cardiac output to improve the central venous saturation, to improve the delivery. But how is the quality on the level of the tissues? Carbon dioxide gap. Yes. Carbon dioxide gap can be used to monitor the microcirculation. Look at this graph. One from the most common mechanism of shock in sepsis is heterogeneity. What is heterogeneity? As well as edema. Heterogeneity is, this is the microcirculation. We have microvessels, which is well perfused, and another neighbor vessels, which is not perfused well. This is heterogeneity, one from the most common mechanism of septic shock patient on the level of the microcirculation. If you can see it here, the area which is not hypoperfused, suppose carbon dioxide coming from the arterial side in the area of not perfused, carbon dioxide is supposed to be accumulated here in this area. We call it carbon dioxide stagnation phenomena. It will be accumulated here. But fortunately, the solubility of the carbon dioxide is higher than the oxygen. So it can travel faster and more far than the oxygen. So on the level of the venules, carbon dioxide can move from the hypoperfused area to the veins, increasing the amount of the carbon dioxide on the veins rather than the oxygen. And you can think also here, if you have tissue edema, which is very common to have your patient with shock and tissue edema due to leaking of the endothelium, right? And the glycocalysis disruption. This tissue edema increase the distance, diffusion distance. Carbon dioxide can travel faster and far away from the oxygen. So here the principle, if you are measuring the difference between the arterial side and the venous side of the carbon dioxide, you can find it high because carbon dioxide can diffuse more far than oxygen in the hypoperfused microvessels, give you this amount of the carbon dioxide gradients. I'd like to thanks and appreciate one of our colleague, Dr. Zainab. She just published 2 days back this meta-analysis about carbon dioxide gap in critical ill patient systematic review and meta-analysis in critical care medicine. She's working now in Canada, and she's from King Faisal Specialist and Research Center, one from our colleagues here in Saudi Arabia. Very nice meta-analysis, still in the online. She found that patient with shock stage, mainly the medical and surgical ICUs, high carbon dioxide gap associated with increased mortality with odds ratio 2.2, as well as higher lactate level, low cardiac index, and central venous oxygen saturation. And very nice statement I do like in her conclusion. Shall we target carbon dioxide gap closer for the station of the patient with shock? Yes, and it needs further area for research. If you are closing the gap, your patient will improve. I hope so to confine this research later on. Again, another flow chart. Let us put everything together. If you have the patient with high lactate, so what you will do, just take a look on central venous oxygen saturation. If you did find it less than 70, one of the four, if you remember the equation, either we have problem with the increasing oxygen demand, like pain, like temperature, so this patient need analgesia or antibiotic. If your patient have low hemoglobin, just try to correct. 7 is enough, unless your patient have acute bleeding or ischemic heart disease, you need to go higher to 9. If you have the patient with low oxygen saturation, this is the cause of the central venous oxygen saturation low, just increase your FiO2. Try to increase his oxygen delivery. If your patient has fluid responsiveness, give him fluids. If he's not responsiveness, give him inotropes. Right? Until central venous oxygen saturation going higher, more than 70. Please take it one by one from the sedation, anemia, hypoxemia, then fluid responsiveness. Don't rush to the fluid responsiveness without assessing the fixed parameters you have, which is affecting central venous oxygen saturation. If you did find your patient with high central venous oxygen saturation, at here, you need to look to the microcirculation. In this stage, you can take a look here. This patient have normal MAP, but he have problem with the tissue mark with the hypoperfusion indicators. We don't have problem with the macrocirculations. So such patient with high central venous oxygen saturation, consider carbon dioxide gap. The normal less than 6, between 2 to 5. If you did find it more than 6, almost. Further increasing cardiac output can improve the oxygen delivery, can clear more lactate in such case. If you did find it normal gap, at that time, you have to disclose. No benefit from high cardiac output. Search for the definitive management. Wait for the infection to be treated. At the end, take a look to the lactate after 2 hours. If lactate is cleared more than 20%, you are in the proper way. If not yet, go back again to the chart and reassess again the same chart. And another message, if you have the patient with normal lactate, whatever central venous oxygen saturation, don't go further. His normal patients, right? Of course, you have to exclude another factor of the hyperlactemia. We are talking about lactemia due to hypoperfusions. So this is a very nice flow chart to give you a clue how to deal with the tissue biomarkers in consequences. Those on the level of the cells. What about the microcirculation? Yes, this is another dilemma, another part. It needs another lecture. I hope you have to have. We can have it specific for microcirculation. Many techniques. Again, static also dynamics, direct and indirect. The most common of it is direct visualization of the microcirculation using cytochem. Of course, many literatures coming, and also some guidelines to tell us about the consensus in 2018, updated by the those figures, the Kanenchi, and as well as the Baker, all of them they have some recommendation using microcirculation parameter assessment for the patient with shock stage, right? And many editorials published, shall we use it microcirculation parameters as a target for resuscitation of our patient? Some of them said yes, some of them said no, but I'm saying I'm going with Xavier Monet, which he said not yet well developed. Yes, pathophysiology, we agree that coherence has to be between macro and microcirculation. Microcirculation has important part in the shock stage, but technology and the therapy still going researches, and we need to be in clinical practice as much as we can. Almost, I touched most of the 3 phases of the shock stage on the level of the cells, as well as microcirculation and the macrocirculations. But at the end of the day, whatever your choice, whatever the company promoting its device, whatever you have any parameters in your ICU, when you're dealing with shock patient, just remember the first one. Very funny. A fool with a tool is still a fool. As I told you earlier, the first and the most important one is a physician. If you cannot interpret it, nothing will be done. Hemodynamic parameters will never improve outcome by itself. You have to have the insight and the interpretations and the intervention to improve based on the hemodynamic tools. Another important message, no one size fits all. You cannot drive your car in different road with the same speed, right? I cannot say when somebody telling me the normal cardiac output is 5 ml, 5 liter per minute. The normal MAP is 65. No, I don't have normal. I have adequate. I have parameter which is fitting me, not fit you, not fit the other one, right? So please, if you have adequate parameter, this is the normal of these patients. Don't think usually the higher is the best. No, higher cardiac output is not the best. Higher central venous oxygen saturation is not the best. It looks like you are striking the tired horse. Don't give more in troops. Don't give more and more and more. And of course, dynamic is always better than statics, as well as continuous is more preferable than intermittent. Of course, invasiveness is essential, but is not the only issue to think about it. The highest invasive technique, still there is a place for it. The last message, hemodynamic parameter is not a single parameter. You have to integrate, you have to combine all the variables you have, and you have to collect your puzzles. For example, oxygen utilizations, spectroscopy, central venous oxygen saturations, tissue perfusion parameters, oxygen delivery parameters, macrocirculation parameters, collect all to reach to your target. At the end, thank you so much. I hope I delivered a message. Hemodynamic, it is an art, it is a tools. Please use it properly. Without you, nothing will be done. Thank you so much.
Thanks so much, Prof. Mady, for this lecture, as usual. So I have 2 comments quickly until we get enough questions here. So the first one is I actually expected to hear something about endothelial glycocalyx, the new theory of separation between the microcirculation and the macrocirculation, which is the difficult cornerstone in the management. We can assess the macrocirculation, but we cannot really assess the microcirculation, and the theory behind endothelial glycocalyx is coming too fast in the last 2 or 3 years. So what do you think about this theory, and how practical we can approach the microcirculation depending on this theory?
I'm totally agree, of course. Glycocalyx, yeah, by the way, my son was studying the first year of the Faculty of Medicine. He was studying glycocalyx. I told him, oh my God, I am now in the 50s and I'm just knowing about the glycocalyx. Glycocalyx is something which is coming over the last 10 years. All of us know from the, what I was studying in the Faculty of Medicine before, they are giving us 2 important factors affecting the filtration or reabsorption of the oxygen at the level of the tissue and the microcirculation. One of them is hydrostatic pressure, one of them is the oncotic pressure. Those are the main two components we have for diffusion of the oxygen at the level of the microcapillaries, right? But really, we have now another very, very important force, which is the glycocalyx, the very thin protein layer covering the endothelium. They did find one from the very important mechanism of the septic shock patient disruption of the glycocalyx. It plays a very important role in the leaking of the fluids and the blood from the fluids and the molecules from the microcirculation. Agree with you so much. Not yet in practice of the clinical practice, but there are some researches targeting glycocalyx integrity of the glycocalyx and management of the patient of septic shock. All of us knew that normal saline have a lot of debating nowadays worldwide, right? They mention it now as abnormal saline, not normal saline. Why? One from the drawbacks of normal saline, it's causing disruption of glycocalyx. So they are searching now about the components or the intervention which play a role in maintaining the integrity. For that, even if you are following up with the fluid management of the patient with septic shock, there is some space for the albumin. Why? Yeah. Because not only oncotic pressure, no, but because it can maintain the integrity of the glycocalyx. It's play a role. I hope they can find the proper way which can help in maintaining its integrity. Very, very advanced. And thank you, Walid, for this point. But the time is limited to go in details about it.
Yes, perfect. So until we get a few questions here, I'm putting the poll to document your attendance. So first question is, I think there is a bit of confusion here from Ali Saad. He said, is the passive leg raise test is more sensitive and dependent than ultrasound or echo, especially if not available for septic patient? I will comment first to Dr. Ahmed and then give you the mic. So the passive leg raise test is not either or with echo or ultrasound guidance. This is an area of interest for myself. So you can combine LVOT, VTI, or ultrasound guided approaches with the passive leg raise test. So it's not either passive leg raise test or ultrasound or echo guidance. They can be combined together to give you more sensitivity and more specificity. I mean, you are targeting certain patients. If you have good responsiveness, VTI responsiveness, or pulse pressure variation responsiveness, or stroke volume variation responsiveness, and then do a passive leg raise test, and you find there's a good response after the passive leg raise test, provided you do the passive leg raise test in the proper way, this is the time that you consider it positive passive leg raise test. And the mic is yours, Dr. Ahmed, if you disagree with me.
Totally agree with Walid. If you remember my slides, I'm telling all fluid responsiveness tests based on something, which is you have parameter to measure, and you have intervention after this parameter, and you measure this parameter again, right? So passive leg raising test, it is the intervention you are doing in between. So whatever you are measuring before and after, it can be. You are measuring the stroke volume before and after. You are measuring descending aortic flow before and after. You are measuring the pulse pressure variation. You are measuring heart rate. You are measuring the systolic blood pressure. You are measuring IVC. You are measuring whatever you are measuring before and after. It doesn't affect the test. So what did you change here? The intervention you did. Why we change it? Because we have many limitations for the mechanical ventilation cycle. It changes during inspiration and expiration, like low tidal volume, like high intra-abdominal pressure, like arrhythmia. So you are searching for another intervention not affecting by those parameters, which is autologous, reversible transfusion of at least 300 to 500 ml of blood, of his own blood during his shock stage. Thank you so much.
Perfect. So I would really like to switch to the next lecture, but like the questions here are really good questions, and I will give 5 minutes more asking Dr. Amr Salam the forgiveness for this delay. So the first question is a continuation for the last question from Mahmoud Al-Muhassab, and I know him in person. He's asking about a patient with a pulse pressure variation or stroke volume variation cannot be used to assess fluid responsiveness. what is the alternative? Passive leg raise test is used when, like how to assess the cardiac output. I would say, like what's my school doing is a mini bolus and assess for difference in whatever technique you started with, like pulse pressure variation, stroke volume variation, cardiac output, whatever the technique you used, you can give a mini bolus of 250 mils of any crystalloid or any colloids and follow that up, because some people, like traumatic brain injury or high ICPs or whatever, you cannot do a passive leg raise test for them for other concerns. So do you agree with me, or you have any more ideas?
Sure, I did agree with you, but I have a message here for all of you, because fluid responsiveness is a big dilemma in the literature and everywhere, right? So whenever you talk about the hemodynamics, you are considering fluid responsiveness is something like the top of the hemodynamics. Please, fluid responsiveness test rarely to be positive. It is not the standard, especially in the ICU. Okay, great. Usually, the patient coming to you in ICU with he received most of the fluids everywhere, late stage. Responsiveness, it doesn't mean your patient he's requiring a fluid right now. We have another limitation, different dilemma. Because most of you are anesthesia, yes. The variability of the passive leg raise test or whatever the fluid responsiveness in anesthesia patient, because you are the first skewer to him more than the ICU. So timing of the fluid responsiveness, very essential. As Walid mentioned, whatever the intervention, fluid challenging, index expiratory occlusion test, passive leg raising test, just to give a fluid challenging for the patient to assess the parameter before and after, it can be enough for your patient. But don't do it even if you will do for yourself now, passive leg raising test, it will be positive. Every one of us. It does mean you need fluids? Of course, no. Why? Your heart will respond. But the heart of septic shock patient, it can respond. It can respond. But in certain limit, you will fail. Again, it is good assessment. It's very good media for the question everywhere, in all exams, by the way. So study it well, but when you practice it, be wise. Thank you so much.
The last question here, for sake of time, by Ahmed Kuhail. What is the best or better for closing the carbon dioxide or CO2 gap? Is it the nitrogen or the butane, Dr. Ahmed?
Yes. Ahmed Kuhail, one from our eminent fellows, by the way, and I do like his very, very good and highly hard worker. He can notice in my round, I do love to give the vitamin for such patient at the end when blood pressure is tolerating, just to clear more of lactate, to increase more, to improve the heterogeneity. Many trials done about the vasodilators, even nitroglycerins, even the vitamins, even nowadays they are doing with elioprost. Even the beta blocker have a rule for improving the tissue perfusion at the level of the microcirculation. All of them studied, but not yet as solid enough to practice it as a routine or a standard of care, right? So you can use all of them, yes, but still, it's not in the matter of the higher recommendation or high level of recommendation.
Perfect. So the last thing I would like to review with you, Dr. Ahmed, in one of the slides that you mentioned, if the patient is initially an echo, if the patient is normal cardiac function or abnormal cardiac function, I would consider any patient with sepsis or septic shock, as per one of the systematic reviews, is at least grade 1 diastolic dysfunction suspected. So I cannot consider any patient with good contractility and normal cardiac function. We should consider systolic plus diastolic dysfunction as well. So we need to be very careful. We need to get an idea about the echo, how to assess left ventricular systolic function, left ventricular diastolic dysfunction, good proper assessment, or like proper assessment before you judge it, good cardiac function before we go ahead. Do you agree, Dr. Ahmed, with that?
I don't have something to say with the experts of the echo and the expert of the, when I'm presenting hemodynamics, the part of ultrasound and the echo, I'm keeping it aside. I don't like to touch so much because I know the people who's expert in this part, the more expert than me, really. So, of course, I am attendee in this one. I'm not the speaker. Thank you so much.
Thanks, Ron. And if you want to add something after the cardiac assessment, you can use the lung ultrasound on the lung basis to detect if any extravascular lung water as another non-invasive tool. It can be used in the ward, it can be used in ED, ICU, it can be even used in home by some paramedic technicians that are trained enough for that. So it's non-invasive, it's a quick tool. You are losing nothing for using that one. So basic echocardiography and lung ultrasound are good helping tools in this aspect. My full appreciation, Dr. Ahmed, for this very nice night and this comprehensive talk. And I am never satisfied enough or never saturated enough with your talks, but it's for sake of time. Thanks very much, and you can stay with us. There is few more questions if you can answer them in typing in the Q&A section from Fatma Al-Hammadi, Alauddin Mitwalli, and Muhammad Hassanin. Just for sake of time, we'll go for the next speaker here,